Physicians encounter a wide range of patient emotions on any given day, and it's important to remember that emotion does not necessarily equal distress. However, there are situations when a patient's emotional state may be causing him a significant amount of distress. This training module aims to help you recognize certain forms of emotional distress and navigate your patient encounters accordingly. After completing this training, you should be able to recognize some of the most common types of emotional distress that physicians see in clinic and hospital settings: the anxious patient, the angry patient, the sad or possibly depressed patient, and the suicidal patient. You'll also learn some tips for engaging with patients experiencing these forms of distress, including some examples of what to say and what not to say. And you'll also have a better idea of what information your attending physician might want to know with respect to a patient in emotional distress. Ways to manage patient emotional distress, as well as your own, will also be briefly introduced in this presentation. We'll look at each one of these types of emotional distress separately. Some of the clinical manifestations and techniques for interacting with patients may overlap or have broad applicability, and others may be more specific to a particular emotion. However, it's key to understand that these skills are different from many of the manual skills that you'll learn, such as suturing. Where those skills may have clearly defined right and wrong ways to proceed, responding to patient emotional distress will require you to draw on an array of techniques that you will practice and refine over time and with experience. Also, one quick but necessary clarification here before we get started. It's very important to understand that sadness, while grouped with depression for purposes of this training module, is not the same thing as depression. We'll look at both of these types of distress in more detail later. A popular interviewing technique for responding to distressed patients is described by the simple mnemonic NURSE. Similar to the type of open-ended question inquiry that you likely have learned in your clinical medicine classes, NURSE uses concepts from motivational interviewing to help understand the patient's situation and to respond empathetically. If you find protocols useful, being familiar with the NURSE acronym, which stands for naming, understanding, respecting, supporting, and exploring an emotion, is a great place to start. Alternatively, if you feel like you have enough mnemonics in your head for the time being, you could also respond to a patient's emotional distress with something like, "What are you most concerned about?" or "What's bothering you most right now?" Here are some sample statements from distressed patient encounters. Notice how each one uses a stage of NURSE. The first example names the emotion, angry. The second one attempts to show understanding of the emotion, I can imagine. The third one responds, while the fourth one supports, I will be with you during this procedure. And the last statement opens the door to explore the emotion further. If you are viewing this in a small group session, you may find it useful to briefly practice some NURSE scenarios with a partner. As we've said before, there's often not a clear right or wrong way to talk with patients in emotional distress. However, on this slide there are some tips from experts in communication, behavioral science, and social work that may help you arrive at a positive outcome with a patient. Of particular importance is the first point: avoiding questions that start with why. The reasoning behind this is that a patient may mistake your question as accusatory and become defensive. It tends to be easier for a patient to respond when you simply ask him to tell you more in a general fashion than for you to say something like, "Why are you sad?" Similarly, saying that you understand a patient's feelings in a way that suggests that you personally know what they are going through can often seem belittling to someone in distress. Consider the last time you were upset and someone said, "Oh, I completely understand." Did you feel like the focus shifted from you to your listener? Did you feel like they didn't really know what you were talking about? That's how many patients feel when we try to empathize by saying, "I understand." In many cases, you won't be able to understand, but you will be able to respect the patient's emotion and be curious about what it means to her. And just a quick clarification, this doesn't mean you can't use the words "I understand." Many positive interviews proceed on something like, I understand you've had some tough times at home lately. Just be aware of the intent behind the words and try to keep the focus on the patient, not yourself. The last general concept to cover before we start examining the specific types of distress is one of self-awareness. A patient's emotional discomfort will trigger emotions in you. It's part of what makes good, empathetic physicians. If you practice noticing your own reactions, you will find it easier to maintain a sense of calm and help patients in distress. Mindfulness meditation techniques have been incorporated into many curricula and training programs with tremendous success, and you may find it helpful to explore this type of practice, especially if you encounter distressed patients regularly, or if you find the encounters that you do have to be particularly difficult for you personally. A few resources on the subject of mindfulness will be available at the end of the presentation. For now, though, just try and notice your own feelings as we go through the scenarios in this module. The first type of patient in distress that we'll consider is the anxious patient. An anxious patient is not necessarily the same thing as a patient with the clinical diagnosis of anxiety disorder. Many situations can cause a person to feel anxious, and going to the doctors is certainly high on the list for many people. Anxiety as an emotion, and the feelings we typically associate with it, dread, fear, foreboding, nervousness, are often accompanied by sympathetic symptoms, like an increased heart rate or sweating. So anxious feelings are not just in the patient's head. They cause very real physical changes. You may see patients that complain of tense muscles, insomnia, or gastrointestinal problems, for example, and those could all stem from anxious feelings. It's also worth noting that certain physical and psychiatric ailments can cause symptoms that mimic anxiety, such as endocrine abnormalities, arrhythmias, and psychoses. Your role when encountering an anxious patient is twofold. Number one, explore the anxiety to find out things like what triggers it, how long it has been happening, how severe it gets. And number two, be as calm, present, and empathetic as possible. Try to notice your own physical reactions to the anxious patient and practice staying still, breathing regularly, and focusing on letting the patient move through the nervousness without becoming jittery yourself. A simple mantra sums this up well. Don't just do something, stand there. Anxious patients benefit from calm, present providers who listen to their concerns. You don't need to jump to a solution right away. Just be there with the patient. Once the patient has been able to tell you his story, you may notice an improvement in the anxious feelings. It may be very subtle, or it may not actually occur. At this point, you might try a simple technique that can help educate the patient about a common mechanism for coping with anxious feelings. Deep breathing, when tailored to a patient's situation and abilities, and done alongside the patient, can be a quick exercise to alleviate some anxiety before he sees the attending physician. Many patients will go on to use these types of exercises as part of their daily routine. Here is an interaction between a medical student and an anxious patient. Try to pick out a few of the practice tips that the medical student uses, and think about how you might incorporate them into your interviews. Also, remember that this medical student has tailored the breathing exercises she uses to this particular patient's capacity. You will want to be mindful of doing the same for your patients. Not everyone is able to hold his breath as well as this patient.
Bill?
Yeah.
Hi, I'm Deanna Glassman. I'm a second-year medical student. I'm here just to start your interview before you see Dr. Smith. How's it going today?
I'm okay. Hospitals.
Hospitals make you nervous?
Well, I guess I'm a little bit more nervous than usual.
Okay.
Lately.
So you're always nervous?
Well, lately I've had some anxiety. I'm here because I have these aches that I feel like they just come out of nowhere, and I got on WebMD and I saw that cancer is something that is associated with that, and I knew it. I knew it in the back of my head that this is it,
Yeah.
it just, this has happened in my family before, and I'm sorry,
It's okay. Bella, it's very normal for people to feel nervous about these types of things, especially if it runs in the family. And I want to assure you that Dr. Smith is going to do a full checkup today, and we'll leave today knowing what's going on. So just want you to take a deep breath for me, and we'll talk about it some more. So you said you were more nervous today. Has this been going on for a long time?
I mean, it's been going on for as long as it's been going on long enough for me to know I have cancer. I mean, how long would it have to have gone on?
Right.
I mean, in the last week. This is when it's happened to me.
Okay.
I got cancer in the last week.
Do you feel this way all the time, like all day long, or does it kind of come and go? Or kind of tell me more about what it's like when you feel nervous.
I mean, it's not the nervousness that I'm concerned with. It's the cancer.
Right.
So I mean, the anxiety comes from me feeling these aches and pains that I know. I mean, my impending,
Yeah. I know that you're concerned about the cancer. I'm just a little curious about what types of things you feel when you're anxious. Do you feel short of breath? Do you feel like you're going to pass out?
I mean, not necessarily pass out. I do. I mean, I feel like an enclosure, and I just feel like the world is just on me, and it just, I can't escape from it. It just is,
Yeah. Okay.
But I feel like that's normal for somebody with cancer.
Right. Well, how frequently do you feel like that? Is it all the time, or is it just kind of occasionally when you think about it?
It's in the last. I mean, it's come on lately.
Yeah.
It's come on because of the feelings, because of the aches and the pains.
And your concerns?
Yes.
Yeah. Well, I have a quick question for you, Phil. There's a breathing exercise that helps a lot of people when they feel nervous and anxious. Would you be willing to give that a try right now?
Yeah.
Okay.
I think so.
Okay. It's really, really simple. What I want you to do, and I'll do it with you, is it's called the 4-7-8 breathing method. So we're going to breathe in for 4 seconds, then we're going to hold our breath for 7 seconds, and then we're going to slowly breathe out for 8 seconds. I'll do it with you, okay?
Okay.
So I want you to take a deep breath
Do
for
I just
4
sit
seconds.
here, or?
Yeah, you can just sit, just be relaxed.
Okay.
Just going to take a deep breath in for 4,
Okay.
Ready? And start to breathe in. And hold it. Okay, and breathe out, nice and slow. Excellent. Let's do it one more time. Breathe in. And hold it. Great. Now breathe out, nice and slow. Excellent.
Is that right?
Yeah, you did it great.
Okay.
You feel a little bit better?
A little.
Great. All right, well, I definitely want to talk more about your concerns, and I want to go and get Dr. Smith to come in here, and we'll do a thorough evaluation of what's going on, and we'll find out what's making you feel so nervous.
Okay.
Okay?
Thank
Great.
you.
I'll be right back. Thanks, Phil.
So what worked in that scenario? The student did a great job exploring the history of the symptoms, and she was genuinely empathetic. She also crafted a breathing exercise for the patient and practiced it alongside him. As far as room for improvement goes, well, it may get you into a bit of hot water if you promise a patient concrete answers from an office visit that are, for one reason or another, impossible to obtain. It's probably safer to say something like, "We'll do our best to figure out what's happening today." The next type of distressed patient is the angry patient. Anger is a familiar emotion for most people, and angry patients are often quite obvious in a clinical setting. Perhaps the reason for their visit to the physician is making them angry, or perhaps there's something else going on in their lives. Whatever the case may be, chances are you will have a good sense when a patient is angry. Verbal cues like gruff demands and annoyed, resentful, or frustrated tones can clearly show anger, and nonverbal cues, such as clenched jaws and avoidant eye contact, can also signify that a patient is experiencing this type of emotional distress. When interacting with an angry patient, it's very important to let her vent her feelings whenever possible. You should do your best to remain calm and position yourself in a non-threatening fashion, such as leaning in towards the patient, rather than puffing yourself up, crossing your arms, or sitting rigidly. Often patients are angry at a provider, or even at the staff member or student in front of them. And though it can be challenging, a very useful technique is to acknowledge the patient's frustration and apologize that she's feeling that way, without actually accepting the blame or deflecting it onto someone else. Nevertheless, While it can be useful to apologize and allow the patient to vent, you should also be okay with setting limits to the conversation. Patient anger is rarely personal, but that doesn't mean you have to be a punching bag in order for the situation to resolve positively. Setting reasonable limits in a calm, cooperative fashion is sometimes necessary. This video shows the interaction between a medical student and an angry patient. Try to pick out a few of the practice tips that the medical student uses and think about how you might incorporate them into your own interviews. Hi, Mary. What's going on?
I already talked to you. I thought it was Dr. Smith, finally.
I know. I'm sorry you've had to wait so long. Dr. Smith is just a little behind today. He tries to take
No
a-
kidding.
I know.
I've been waiting for over half an hour. My appointment was at 9.
It's been one of those days for sure, and I know that he's very interested in seeing you. And
Well, what's taking him so long?
sometimes patients have things happen that they weren't expecting to happen in their
Yeah,
appointments.
and that's why they have their appointment time and I have my appointment time.
Yeah.
And it's not fair to me that they get extra time and I get less time.
It's super
I'm pretty sure I'm
frustrating.
paying the same amount for this visit as that patient he's with right now.
I think you're probably right about that. And I'd like to find some way to make this a little bit easier for you, because I
Mhm.
know it sounds like it's really frustrating for you. It's a little hard for me when you're yelling at me, but I do want to try to
I
find.
wouldn't really call this yelling, but okay.
Okay, well, it's a little hard for me when you're upset, and I'd really like to find a way that we can work on this together. Is there anything that I could do to make this time easier? while
Well,
we're
for
waiting
one
him?
thing, I mean, it's summer out. I'm dressed for summer and it's like fucking Arctic freeze in here.
You know, they keep it really cold in here, and I can definitely look for a blanket for you or some sort of like a cover. Would that help?
Yeah, that'd be nice actually. Yeah.
Okay. What about it? Is it like a magazine? Would that help? Is it
I mean,
certain
I,
thing-
I really hope I don't have time to
I
read a
know.
magazine before Dr. Smith gets in here, but I guess that'd be good.
I do too, and I really am sorry that you've had to wait this long. It's super
Is he
frustrating.
at least is he coming
He
in
is
the
coming.
next, like 10 minutes or
I
something?
saw him in the hallway and we chatted briefly, and I
Okay.
just had to see one patient before you. So what if I get this blanket in a magazine and hopefully he'll be here within the next 5 or 10 minutes. Would that work?
Okay, yeah, sure. I mean, hope he gets here.
Okay, I'll be right back.
All right, great, thanks.
So how about that scenario? The student did a good job allowing the patient to vent, and he apologized with an explanation that didn't really blame anyone. But he also had some trouble setting boundaries with the patient. Things got a little dicey when he accused her of yelling at him. And while the student did a nice job allying with the patient and agreeing that long wait times are annoying, he didn't spend much time finding out if the patient had other reasons to be angry. Saying something like, "I can see how this is really annoying to you right now. How's the rest of your day been?" might help to steer the interview into an area where the student and patient can have a less contentious conversation. The next form of emotional distress we'll discuss is sadness. Like anger, sadness is a familiar emotion for most people, yet it may not always present as the obvious tearful patient in the clinic or hospital. Sometimes a sad person may just be quieter or more lethargic than usual. It's critical to remember that sadness is often a normal reaction to loss or disappointment, and it's not always pathological. Depression, on the other hand, though sometimes conflated with sadness, is a chemical condition that causes chronic symptoms for patients. Someone with the clinical diagnosis of depression may not necessarily present as what we think of as sad. In fact, many patients complain more about somatic symptoms like sleep and energy levels than they do of feeling outright sad. The main point here is that sadness and depression are related, but they are not the same things. A thorough interview can help to distinguish each case. If a patient presents with sadness, she may want to talk about it, in which case you can begin probing things like onset, duration, and aggravating or minimizing factors. This can help both you and the patient determine whether the sadness is a temporary reaction or a more long-standing condition. If the patient isn't interested in talking about the sadness, at a minimum, you should try and find out whether he has a support system. While interviewing a sad patient, it's particularly important to let the patient talk and refrain from giving advice. At the same time, approaching the sadness in a non-judgmental way can help the patient feel comfortable exploring it. Remember, sadness in and of itself is not abnormal. However, in all cases of sadness, it's a good idea to investigate suicidal ideation with a gentle question like, "Have you ever thought about suicide?" If the patient gets defensive, you can always say something like, "Oh, I'm trained to ask this of everyone who's feeling sad." It's of paramount importance, though, that you explore this, because you simply can't determine if a patient is having these thoughts without asking. For patients that present with what seems a disproportionate amount of sadness, it's a good idea to screen further for depression, and you may find this SIG-E CAPS method helpful. It starts with questions about relatively innocuous issues like sleep or energy, and the conversation often will unfold naturally into other areas like concentration and appetite changes, giving you a better picture of the situation. And, just like with sadness, if you suspect depression, you need to screen for suicide. Here is an interaction between a medical student and a sad, possibly depressed patient. Try to pick out a few of the practice tips that the medical student uses, and think about how you might incorporate them into your own interviews with sad or possibly depressed patients. Before I get Dr. Smith, is there anything else that you want to talk about?
Well, last time I was here, they started me on this medicine that was supposed to make me feel better. I just feel like I've been gaining weight, and I feel really unattractive, and I don't see my husband that often, and now when he's home, I feel like he doesn't want to come home to me anymore, and I feel worse, and I don't know if it's the meds, I don't know if it's my home life, I don't know if there's anything you can do about that.
Well, it sounds like there's a lot going on that's making you feel sort of overwhelmed and sad. And you say this started about a month ago?
I told them it was about a month ago, but I think it's been a little bit longer than that.
How long would you say it's been?
Maybe three or 4 months. I
3 or 4
lost my
months.
job a few months ago, which is why my husband's been working longer hours, and I've been kind of on my own with the kids, taking care of them. It's hard.
Yeah, that sounds difficult. Before that, how did you feel?
Before that, I felt great. I miss that person.
Yeah. And is there any way currently that you see that person coming back? Are there any activities that you like to do you don't feel so sad and lonely?
Every once in a while, when my husband has a day off, we'll spend time with the kids again and feel like a family again, and those are good days. And I keep telling myself that I need to do things on my own, take the kids out. I know they don't like being stuck in the houses. Same with me, but I just don't have the energy. Sometimes I'll even pack the bag and get us ready to go to the park, and I just want to go back to bed or take a nap.
It sounds like you're feeling a little fatigued or tired. Is that right?
Yeah.
How are you sleeping?
I'm not sleeping very well at night, but then in the morning I'm really tired, and all I want to do is sleep. Stay up for hours when I try and fall asleep, and then I'm so tired during the day.
Yeah. What about your appetite? Are you able to eat?
I haven't been eating as much, and I think that's also been frustrating because I've been putting on this weight, and I don't know where it's coming from.
That's a pretty common side effect for that medication. It's something that I know it doesn't make it any easier to hear that, but it is something that a lot of people experience.
And I could handle that if I were feeling better, but
Yeah.
it's not making me feel better.
It would be easier if it came with positive mood or something like that. It sounds like.
Yeah.
Well, tell me something. Sometimes people who are feeling sad or lonely, they think about hurting themselves. That's not something.
No, I would never do that. I love my daughter so much.
It sounds like you have a lot going on that's good in your life.
I do.
Yeah.
I do.
Well, what I'd like to do is bring in Dr. Smith, because it sounds like you are still having some sadness, and maybe there's maybe there's something that we need to do about the medication or come up with a little bit of a different plan to help you to get through this period. Would that be okay with you if I bring him in and we talk about this?
Yeah, I would like that.
Okay.
I think that'd be really helpful.
Great. Well, I'll just go grab him and we'll be right back.
Thank you.
You're welcome. Any thoughts on that scenario? The student did a good job exploring the sadness and found out what kinds of support the patient had in her life, but there were a few instances where he missed a chance to empathize with the patient. This is a common challenge when talking with distressed patients. You will want to get details from them, and you may be busy thinking about the next question to ask when they say something that would cause you to pause and empathize if this were a normal conversation with a close friend. Try to be aware that a simple, "Oh man, I'm really sorry," or "That sounds tough," can go very far in making the patient comfortable and building rapport. Also, as a technicality, this student should have directly said, "Have you ever thought about suicide?" Hurting yourself is not the same thing in many people's minds, and it's extremely important that you clearly explore suicidal thoughts in any sad patient. Suicidal ideation means that a patient has been thinking about committing suicide. These thoughts can accompany depression at any level and vary tremendously in their frequency, specificity, and intent. Sometimes a patient will indicate suicidal ideation on a screening form, like the PHQ-9 depression questionnaire used in many primary care clinics. And sometimes a patient will simply say something like, "I just wish I wasn't here." In either case, your job is to gently, yet thoroughly and directly, inquire into the nature of the suicidal thoughts. In order to fully assess the risk of suicide, a patient's thoughts about the act, intent to commit the act, and plan for carrying out the act must be examined. It's very important to be calm, deliberate, and non-judgmental when interviewing a patient with suicidal ideation. You want to show the patient that you care about their feelings, and you can express genuine concern, but you also need to collect information about the suicidal ideation so that the attending and other professionals can intervene most appropriately. Think about how you might ask a patient something like, "Have you thought about how you would end your life?" Or, "Are you willing to get help?" If you're viewing this module in a group setting, you may want to pause and practice asking these follow-up questions with a partner. Here's an interaction between a medical student and a suicidal patient. Try to pick out a few of the practice tips that the medical student uses here and think about how you might incorporate some of them into your interviews.
My life is spinning out of control right now. I mean, I just lost my job. I mean, my wife left me. My daughter went with her. I mean,
Oh, that's a lot on your plate.
Yeah. And I mean, yeah. So, I mean, on top of probably not even being able to pay for this doctor's visit anymore. I mean, so things aren't going very well.
Wow. So now that things aren't going so well, how are you coping with that? Do you have family that you can talk to, or?
No. I mean, my extended family is gone, and she was all I had. My daughter really was all I had left to look forward to. So, I mean, without her, I don't know.
Can you tell me a little bit more? You say you don't know. What do you mean you don't know?
Well, it's without her, I feel like she was my reason. And without her there, I don't even know if I can wake up in the morning.
Can you tell me a little bit more about that?
Well, it's just like this. I mean, I know they're going to be gone. I know they're going to be gone forever. I mean, she hates me now. And I know that my ex-wife is telling her all these things about me which aren't true. They aren't true. Mm. And it just is like, I mean, if I can't even see her, then why am I here? I mean,
it seems like you're really, really frustrated by this whole thing.
Yeah.
Is there anything that some people when they get this frustrated in these life events that happen, they start to have these thoughts about hurting themselves or hurting others. Is there anything like that going on?
Well, I mean, I would think that it's impossible not to. I mean, I have this horrible hole left in me that I can't I mean, to tell you the truth, I have a gun, and I definitely have thought about it, especially in the last week or so, just about taking it and just being done, just being over with all of this BS that that she has saddled on me, and I think about my daughter's face, and I just can't. I don't know if I want to be here anymore.
Have you ever thought anything like this in the past? Any feelings of wanting to end your life?
No. This is very recent. This is all since she just gutted me.
Yeah.
And
do you have any specific plans in place of when you would want to do this?
Well, I think that it was one of those nights, when you just start drinking and it just swirls around my head.
Yeah.
And I have thought about it, and I've taken the gun and I've held it, and I've thought about just doing it, but I haven't really thought of a plan. I think it would be one of those things where she would call me and I would do the same thing again. This happens to me every time, where I just start drinking and I start thinking about it, and then it would just be so wonderful to just be done.
Definitely. So a lot of things you're talking about here are certainly concerning. Concerned about your health and concerned about your safety. Things I'd like to talk with Dr. Smith about, and have a conversation with all three of us here to just kind of delve deeper into what's going on with your life, see if we can get you some extra help and support, especially since you mentioned that you don't have any extended family. Would you be willing, if I brought Dr. Smith in here, we can kind of talk about this a little bit more?
Yeah.
Okay. All right. Well, you stay here, and I'll grab Dr. Smith, and we'll come back and we'll continue the conversation. Okay?
Okay.
How was that encounter? The medical student did an excellent job exploring the vague statements that the patient was making, and she reacted non-judgmentally to his answers. But she forgot to ask directly about suicide. Remember, thoughts of hurting yourself or others is an important concept and is certainly worth exploring, but it is absolutely not the same thing as directly asking about suicidal ideation. Also, when it comes to suicidal patients, you want to be careful about giving them room to object to treatment plans. It would have been better for the student to say, "I need to involve my attending," without asking the patient's permission. In this scenario, the patient was fine with it, but you can see how that could easily not be the case, and then you're forced into a tricky spot with a potentially fragile patient. Duties may seem like a heavy word, but suicidal ideation is a serious emotion, and as a part of a healthcare team, you must treat any mention of suicide with utmost awareness of the stakes. During your interview, you may get a sense of how serious the risk is, and indeed, a well-reasoned, lethal plan with a strong sense of intent behind it suggests that a person is at great risk. But under no circumstances should you ignore the emotion. You must involve an attending anytime suicide is mentioned. And this is one area where, as we mentioned earlier, the patient's desires should be subordinated to the patient's safety. Though many patients will welcome the offer of help, it is just not okay to keep suicidal thoughts a secret between you and the patient, even if he asks you to. This concludes the Distressed Patient Encounter training module. You've seen some of the most common forms of emotional distress that patients experience, and hopefully you've learned a few tips for navigating your encounters with them. A few closing remarks and resources to take with you. Number 1, remember the nurse framework for interviewing patients and responding to emotions of distress. You will definitely be encountering scenarios where you can use this helpful approach. Number 2, be mindful of the emotions that you experience when interacting with patients in distress. A meditative practice can help you cope and maintain a sense of calm in difficult environments. A good place to start for mindfulness practice is the Center for Mindfulness, listed here on this slide. Number 3, remember that you must always involve an attending as soon as reasonably possible when a patient describes suicidal ideation. This module does not serve as training for intervening in such situations. Most clinics and hospitals will have designated crisis management individuals and resources. But A good national one to know about, the National Suicide Prevention Lifeline, is listed here in case you find yourself in a setting where such resources aren't easily accessible.